All right, good morning. Welcome to Pediatric Grand Rounds. My great pleasure to welcome all of you today. And as always, we'll start out by pointing out the upcoming Grand Rounds. Next week, we're going to hear about emerging as an equity-minded academic medical institution, the third dimension to achieve excellence. And then the following week, Bonnie Maldonado will give us an update on the current epidemiology of COVID-19. I also want to draw your attention to the Department of Pediatrics website because we've had a remarkable series of COVID-specific grand rounds over the last 2 months. This has included topics such as ethics, telehealth, education, always updates from Bonnie on the science. So it's really quite an extraordinary resource, and that's available to everybody through the Department of Pediatrics website. And on to the next slide. And then just a reminder that every June we have our Staff and Faculty Awards Day. You can see here there's a long list of awards to honor the contributions of our faculty and our staff. We really encourage you to nominate people. Very importantly, the deadline is June 12th. So please work with your colleagues, and there's so many deserving candidates for both the awards for faculty and the awards for staff. Next slide. All right, so my pleasure to introduce our speakers on the perinatal care in the context of COVID-19. At the California Perinatal Quality Care Collaborative and the California Maternal Quality Care Collaborative are crown jewels, not just in the Department of Pediatrics, but really across the entire state of California. And I want to give a special thanks to Susan Hintz, who sent me a lovely summary of all the really important work that this group is doing specifically in the context of COVID-19. And we were so pleased that this panel was able to come together to tell us all about that. As you can see from the slide, we have a very distinguished lineup of speakers. So I'm going to start by introducing Dr. Henry Lee, who's going to kick this off, and then he'll introduce all of our subsequent speakers. So very briefly, Henry did his training here in neonatology, and not only does he have a master's in epidemiology, but he did a UCSF supplemental training program in translating evidence into practice policy and public health. Made many important contributions in education to the Department of Pediatrics, including co-director of the Clinical Research Scholarly Concentration for our residency. He's also Chief Medical Officer of the California Perinatal Quality Care Collaborative. Henry has an extraordinary CV with over 150 publications in maternal and infant outcomes, and in addition to these scholarly contributions, he's co-authored with many of the people here a series of clinical practice guidelines and contributed to digital publications. He has many NIH grants on topics such as a dashboard of racial ethnic disparity in care provided by NICUs, in situ simulation of neonatal resuscitation to improve team performance and clinical outcomes, and improving outcomes of peri-viable birth via an enhanced prediction tool. And then he's a co-investigator with many other faculty doing related work in the Department of Pediatrics. So with that, Henry, you can take it away.
Thank you, Mary, and privileged to be in this group with my colleagues. I'm presenting. I'll introduce briefly. Dr. Natali Aziz is Associate Professor of Obstetrics and Maternal Fetal Medicine, and who I'm privileged to work with, and she's an excellent teacher, a compassionate physician, and she has special expertise in infectious disease during pregnancy. Dr. Alexis Davis, Associate Professor of Pediatrics and Neonatology and Medical Director of our NICU. She's also noted to be a member of the residency graduating class in pediatrics at LPCH, probably the best class that this program has produced. I think that's a general opinion. And Dr. Jochen Profit, who's the Chief Quality Officer of the CPQCC. He's a real role model to me in his innovative research that's worked to reduce disparities, improve outcomes for infants, and also the well-being of healthcare providers. Disclosures, myself, Dr. Davis are advisory board members for Lancino Laboratories, and I receive research funding from Meet Johnson. We have no other disclosures. So when I was asked to participate in this presentation, I was a little hesitant for a couple of reasons. First, I have very little knowledge on this topic, but I recognize that my three colleagues who are presenting with me do have a lot of knowledge, and so I'm grateful for them. They'll do most of the presentation this morning. Second, the little that I do know is that the population of newborns, as far as we've learned so far, seem to be fairly mildly affected or even not at all. And it's in the context of our adult medicine colleagues who've really had so much impact on their patients with COVID, I wasn't sure if we had that much to say. But as we have been working the past 2 months, we have recognized there are a lot of issues that come up in perinatal care. And first thing to note perhaps is that while much of the clinical enterprise that's not COVID related has slowed down over the past 2 months, the Johnson Center has had its regular volume of patients, and even though we call them elective C-sections, they're not quite as elective as procedures that have been postponed in other parts of the hospital. And ultimately, there are a lot of concerns that our patients' families have come to be having to face, such as even whether the hospital is the safest place to have a baby. So our societies have tried to address these concerns, and I know locally as well, my colleagues have worked very hard to make sure that the hospital is the safest place to have a baby. In addition to the concerns of our families, I know that my colleagues who work in the labor and delivery setting have their concerns as well about just coming to work. And as we're social distancing in every other aspect of our lives, it's not possible to do that in labor and delivery, whether it's helping a mother to have her delivery or whether we're surrounding a radiant warmer and doing neonatal resuscitation. There's often several of our colleagues very close together that is impossible to social distance. And if you'll permit me to share a personal perspective, I was just looking at some family albums, and this is 15 years ago. If you've been there recently, the labor and delivery room looks pretty much the same, similar equipment and same curtain, and you may also even see Dr. Jack's Powar in recent weeks. But the difference here is that you could see him in the corner. Dr. Powar is just in a t-shirt, not wearing any PPE, mask or gloves, and he's smiling and holding my wife's hand. And my sister-in-law at the delivery calling family members to announce the good news, and she was there the whole time with me to support my wife, and then the newborn baby's siblings visiting the next day. And these are scenes that are just not seen in these past few weeks. And even, I have photos of nurses smiling, holding the baby, as well as family and friends visiting. And nowadays we have very few visitors to the hospital. So there's even potentially a sense of maybe loss even during this time of celebration. So I was, I was encouraged to, even last week, think about this more as Dr. Kalanithi talked about how we need to be more creative and work harder to show our warmth and compassion to patients. And I know that my colleagues are working hard to do that. And this is even more so perhaps for those moms now as we're doing universal testing who test positive for COVID, even though they're asymptomatic. The fear that they may have for their own health, for their baby's health, as well as perhaps even fear of what the hospital policies may cause in terms of their interaction with their newborn baby. So with all of these questions that are arising for families as well as for healthcare providers in perinatal care, the CPQCC and CMQCC, which are organizations based at Stanford, and sort of lead the efforts of California in terms of quality improvement, thought that we should try to provide some resources in order to help guide the policies and procedures for perinatal health across the state. Just a brief description of these two organizations. The California Perinatal and Maternal Quality Care Collaboratives are consisting of almost all of the maternity hospitals and NICUs in the state, and work on data-driven quality improvement CNQCC has been considered one of the main factors of this contrast between rising mortality in the United States overall compared to the declining rate in California. Their work on a variety of quality improvement toolkits and projects, such as for preeclampsia, reducing C-section rates, and postpartum hemorrhage, have been highlighted in popular media. And similarly, California was highlighted in a CDC report noting that it was the only state in recent years to have a decline in infant mortality. And of course, it's not really fair to attribute a decline in infant mortality to one organization. It's many factors, but a major focus of CPQCC has been to improve practices and outcomes for preterm infants. And these are some numbers showing the improvement over the past decade amongst the CPQCC membership. So within the context of many California hospitals and even outside California looking to CPQCC and CNQCC as an authority of sorts, my colleagues developed a website posting resources for maternity and neonatal care in the context of COVID. And fairly early on, we hosted a webinar that drew on the experience of LPCH because the Bay Area was fairly early in having to think about and implement practices for COVID. This webinar included my two fellow presenters, Dr. Aziz and Davis, as well as Rashni Matthew, Kelly Brennan Lee, and Kay Daniels. This was on March 24th, and it was perhaps really due to timing. We had more than 4,000 live attendees, which was actually more than the 3,000 maximum that our Zoom license was able to accommodate. But it was recorded and is viewed many times afterwards, and I think it did help many of our colleagues across the state implement strategies at their hospitals to account for COVID. We had a series of further webinars that were on issues such as transitions of care, mental health considerations for patients and healthcare workers, as well as outpatient care. And faculty from across the state participated, including Jochen in the mental health considerations webinar. Our website has been viewed more than 45,000 times over the past 2 months. And it's just been really exciting to see the enthusiasm of so many participants and people just wanting to try to share what they've learned so that we can help our colleagues, across many hospitals to learn how to take care of patients better. So I'm going to transition to Dr. Aziz's presentation on obstetrics. What we're presenting today are updated portions of what they presented during that first webinar. And I'll just note that Dr. Aziz, Dr. Davis, and the other faculty, they agreed to participate in these webinars is really, I think, within 5 days of us scheduling it. And so we really appreciated their expertise in sharing with our colleagues across the state and even outside the state.
Good morning. Thank you. And Dr. Lee, I just want to thank you for being such a great leader in putting these webinars as well as this grand rounds together. And also, it's an honor to be here to serve and to present amongst some of my dearest colleagues. So it's really a pleasure. Thank you very much, and for such an important topic. Today, from a perinatal standpoint, I wanted to cover a few things in terms of pregnancy and its relation to COVID. Wanted to talk about the symptomatic presentation, what risk factors and outcomes may be exclusive to pregnancy. Additionally, the very important question of what perinatal outcomes are associated with COVID-19. And then finally, to bring it back home, and very importantly, to discuss some of the implementations of protocols and policies that we've been implementing in LPCH to help our patients and help our healthcare workers to really move forward step by step in this COVID pandemic. And then finally, we'd like to share some of our own experiences in terms of numbers and our demographics, which I think will be very stark for many people. So thank you very much, and we can go to the next slide. So the presentation in pregnancy, fortunately, about a third of patients, or significant, are asymptomatic. There was a New York publication where of the 43 patients who tested positive, approximately 33% were asymptomatic in their as part of their universal screening process. This is actually very similar to our experience, and I'll be sharing that later on, but we actually have about a 39% asymptomatic presentation for our patients, which we capture through universal screening. The other portion of patients with COVID-19 who are pregnant present with symptoms, mostly present with fever, cough, malaise, and dyspnea. The anosmia and ageusia, which is lack of taste and lack of smell, which is commonly reported in non-pregnant women, hasn't actually been reported as much in our pregnant population. And similarly, fortunately, disease severity is predominantly mild in pregnant women. So almost 85% have mild disease, approximately 10% will have severe disease, and then of that, about 5% will be critically ill. Next slide, please. Thank you. So what are the risks of pregnancy and that which is affected by COVID-19? Well, so far, our data is really limited. Although we have so many thousands of patients across the world and across the nation that have been affected with COVID-19, we're still trying to gather data, and there is a dearth of data pertaining to pregnant women. Thus far, however, unfortunately, it does not appear that there's an increased risk of transmission or more severe complications like ICU admissions or deaths in pregnant women compared to the non-pregnant adult. And this is actually somewhat of a difference compared to other respiratory viruses that we have recently experienced, including influenza, H1N1, SARS, and MERS, in which we did observe more adverse complications in pregnant women. So with COVID-19, we are not seeing the increased adverse events in pregnant women over the non-pregnant population. Additionally, we wanted to look at the risk factors that predispose a pregnant patient to being hospitalized and having more severe illness. And there was just recently a new study published from the United Kingdom, which reviewed over 400 women. And it looks like there are certain things that are risk factors for hospitalization. That includes an older age of 35, higher body mass index, as well as Blacks and other minorities in terms of a group ethnic minority population. And that was actually the highest factor. There was actually a 4 to 5-fold, whether it was adjusted or unadjusted, increased risk if a woman was a minority. And then, of course, including as well as other non-pregnant patients, we also saw the same pre-existing medical conditions being an issue and risk factor for hospitalization and more severe disease. Some of the case reports and case series that have actually been reported in pregnancy, which illustrate some of the more severe illnesses, include some case series that demonstrated cardiomyopathy in very ill women. Of the women that were hospitalized in a severe or critical setting, there was about a third or 34% risk of preterm delivery. Additionally, a new case series was just published in Iran, which is actually a smaller country. However, they had represented that of their 9 critically ill patients, up to the point of manuscript submission, there were 7 deaths of the 9 critically ill patients at the time, and 2 were still severely ill in the ICU. And of course, with the UK demonstration and recent publication in UCOS study and manuscript, there appeared to be about a 1% death. Fortunately, it's not high, but 1% is still high enough for us to take note of this. So what are the perinatal outcomes in terms of COVID-19, which affects pregnant women? Our initial reports from China actually demonstrated really reassuring results. There was many case series, and we actually tried to put put these together, and there was at least a 27 case series of infants born to COVID-19 mothers, and of those, none were infected. Additionally, of the infants who had amniotic fluid, cord blood, neonatal swabs, as well as breast milk sampled, none of those specimens or infants had infection or PCR detected of COVID-19. So it was a very reassuring first set of data. However, more recently, and very recently, just within the past week or so, there are very newly publicized case reports and case series. So there has been a smattering of case series that have demonstrated possible placental infection without infant infection, as well as miscarriage with a placental infected COVID-19 case. And then there's possibly some vertical transmission now being published from Italy and Canada. However, these case reports are still very early. We don't have large data, and there is still commentary about the fact that we're still not definitive on if there was vertical transmission, given that the timing of infection is still difficult to ascertain, and the specimens may also have been contaminated with maternal sources. So the question is still to be determined, and we just need more data, and hopefully through CMQCC as well as other registries, we can get to these very important questions very soon. So now we're going to bring it back home to LPCH. And what we've done is we've used a combination of resources to inform our protocols and policies. We've used CDC, WHO, ACOG, and American Academy of Pediatric guidance. So to start off, at our hospital, there is one asymptomatic support person or caregiver for the entire hospitalization. There is universal COVID-19 testing for all admitted patients, including an antepartum, postpartum. There's also isolation of infants with COVID-19 suspected if they have been infected from other healthy infants. And then finally, and probably what's really a very fluid and process that's still in motion, basically, but we update it as soon as we can, the co-location of known or suspected COVID-19 mother and infant and breastfeeding considerations. And what we have done is we've really followed the CDC, WHO, ACOG, and AAP guidance, and we are using a very shared decision-making model where these discussions are held between mothers and the pediatrics team as well as the obstetrics team. So I wanted to also just review a little bit of the California OB COVID-19 experience. And I would just like to say that this is courtesy of Dr. Elliot Main and Dr. Henry Lee from the CMQCC and CPQCC, which we are so fortunate to have located right at LPCH, as two of the directors are here and the institutions are operated from here. So COVID-19 positive and POI obstetric patients seem to present usually on a lower number as that of hospitals. So we usually have seen, of the participating hospitals throughout California, approximately 1 to 3 cases per week that are seen or admitted onto labor and delivery units, and some have even seen fewer. Only a handful of the pregnant and postpartum patients have actually had ICU admissions, and of those, several of the second and third trimester cases were intubated, but fortunately have recovered and been discharged. And that is for most of the cases. And then finally, there's universal rapid COVID-19 testing throughout the California hospitals on labor and delivery. And they test among the asymptomatic pregnant women across California. Seems like the percentage is about 1.5%. But many of the smaller hospitals and lower prevalence areas are less than 1%. And this is quite a stark difference from our New York State colleagues who reported 20 to 30% asymptomatic patients. So this is quite reassuring, and I think it goes to show that California did very many wonderful steps and took wonderful steps to help reduce the number of COVID positive infections, not only in non-pregnant patients, but in pregnant patients as well. Just very quickly, from a LPCH COVID-19 experience, we began our pre-procedure testing. So in an effort to be prepared and have our staff as well prepared as possible, we test our cesarean delivery and other pre-procedural patients in advance. And so we have their status known prior to their admission to labor and delivery for their procedure. And additionally, for laboring patients and inductions of labor, as well as antepartum and postpartum admissions, we began universal testing on April 25th, which has been very helpful and has acknowledged and recognized quite a few asymptomatic patients in our patient population. And so now getting to some of the very important data for our own patient population. So this is a period of roughly from March 1st to May 21st as of yesterday. Of the total patients under investigation who were symptomatic or universal patient testing, we had 498 patients that were tested. Some were tested repeatedly, but this is just of the patients that were tested. We had a total of 13 who were positive, so that is a 2.6 total positive rate. And of the asymptomatic patients tested, we have about a 2% rate, which is similar to that of California. And again, this kind of can vary just by one number, which we had yesterday. Before that, it was 1.5, but we just had a positive patient yesterday, so this brought us up to 2%. And this is very interesting to see because it demonstrates the difference. So in our asymptomatic population, our COVID percentage is 2%. In our asymptomatic Stanford healthcare worker population, just as of yesterday, that percentage is 0.25%. So we are 8-fold higher than our regular healthcare workers. And so I think this goes to show that there may be something different in our patient population than the typical healthcare worker at Stanford, and we'd like to explore that a little bit. So COVID-19 experience, again, of the 18 admissions, a total of 6 were admitted to actually the medicine or ICU unit at Stanford, and 2 of the 6 who went to Stanford were actually admitted to the ICU. Of the Stanford patients, 4 actually received remdesivir. So I think that's an important aspect to highlight as well, because the study excludes pregnant women, but through the assistance of Dr. Subramanian and other ID colleagues, we were able to obtain compassionate use for pregnant patients, which was very helpful, and hopefully this will continue. In our LPCH patients, 12 were admitted for obstetric indications, including delivery or pyelonephritis, preterm labor, for example. Of these, 8 have delivered, 5 were for vaginal delivery, and of the 3 remaining cesarean deliveries, they were for obstetric indications. 1 was for breech and 2 were for repeat cesarean delivery. And so far, fortunately, of our 8 delivered patients, we've had 0 neonatal infections. It's always nice to highlight. So some of the observations we've made from an obstetric and maternal fetal medicine standpoint of the 18 patients that we've observed through Stanford and LPCH, we have seen a very high preponderance of Hispanic patients. So of our 18 patients that were positive, 16 or almost 90% have been Hispanic. And this is a stark difference from our patient total Hispanic population, which is only about 22% as of 2019 deliveries. Additionally, similarly, a big disparity is that of public insurance, where almost 90% of our patients are state insured. And then finally, we have also noted some trends in transaminitis. So of the 8 delivered patients, about 50% had transaminitis, and of those, 38% actually were diagnosed with intrahepatic cholestasis of pregnancy. And that's actually compared to only a 5% incidence of intrahepatic cholestasis of pregnancy that's noted within our patient cohort generally. So, and those are some trends that are also being seen throughout California. And again, during our CMQCC discussions. We have these very lively and informative discussions about these observations that we're making throughout the state. That brings my section to a close, but before I begin my formal acknowledgements, I want to send out my heartfelt acknowledgements to really, additionally, all the medical individuals, medical healthcare staff are unsung heroes. However, additionally, on top of that, I just want to highlight our patients who are unsung heroes, our residents who are really on the front line, and I have so much admiration and respect for residents and nurses who day in, day out are caring for patients who may be COVID positive and who are taking the best care to implement excellent LPCH quality of care, but also promote safety amongst themselves and for other patients. And other individuals on labor delivery, like the techs, the anesthesia techs, the OR techs, the housekeeping, I really feel like those are our unsung heroes, especially on labor and delivery, and I'd like to highlight them. And then finally, my formal acknowledgements are to LPCH Infection Control, who is so near and dear to my heart, and Dr. Matthew and her team, the Obstetric COVID Task Force, whom I've had the pleasure of working with. This talk is in collaboration with our team who put together a Grand Rounds talk just recently this week as well. Dr. Gibbs, Ms. Kelly Brennan Lee, Dr. Igbinosa, and Dr. Lyle, who are my colleagues and my heroes as well. And then just our leadership through Dr. Yasser El-Sayed, who has led labor and delivery in keeping our patients safe, but also providing the highest level of care and really providing care at the highest numbers that we could. So I just want to thank everybody. This has been a really heartening experience, and as difficult as it is for our patients, I just want to say it really has made me realize how wonderful it is to work with my colleagues at LPCH and everybody here. Thank you.
So I'm just going to go over a little bit about COVID-19 infection in the newborn and how we have had to make some modifications in our management of these infants in the delivery room, and then echo some of what Natalie's already mentioned about how we triage these babies. There we go. Okay, so at the time that we convened our multidisciplinary working group with our colleagues in obstetrics, there was really very little unknown in early March. There were these case reports, again, that Natalie mentioned, and this was actually going on during the California Association of Neonatology conference where David Kimberlin was speaking and was privy to some unpublished data about 3 infants who had tested positive, one of whom had respiratory symptoms and another one who was preterm and had a DIC-like picture. So there was concern at the time that although for all the reasons Natalie mentioned, you know, we didn't think there was a significant risk of vertical transmission. I think the question was, is it zero risk? And in the face of those unknowns, how do we conduct ourselves? I think we did acknowledge that most likely the greatest risk to the newborn infant was through horizontal transmission. And here's some examples of how that might happen. There's some controversy about whether stage 2 labor is considered an airborne generating procedure due to, I think the words Dr. El-Sayed uses is the explosive efforts on behalf of the mother. There's a question about we know that the virus has been cultured in urine and stool, and certainly these can be in contact with the infant at the time of delivery. And then obviously the most likely or most concerning risk is exposure during routine care after birth, whether it's skin to skin, breastfeeding, or even just regular things like diaper changes. And so it really underscored the importance of peripartum and postpartum care in helping minimize the risk to the newborn. So when we approach how the delivery room team would conduct themselves in the delivery room, we were working under the basic assumption that if mom is considered a PUI or positive, that the baby is potentially infected and therefore a PUI. And the partner also is considered a direct contact and therefore potentially poses an infectious risk. We know that although the vast majority of deliveries are wonderfully uncomplicated, there is also the unknown, and about 10% of deliveries that require resuscitation, and the decision to do this can happen very rapidly. Aerosol generated procedures are a hallmark of NRP. We do positive pressure ventilation, CPAP, and intubation. And as I mentioned, we need to protect the infant, but we also need to protect our healthcare So this is a publication that came out in early April and highlights a lot of how we approached our management in the delivery room. It has some great graphics, which I'm going to show. This is an international collaboration of neonatologists. Italy and Spain are represented. But I also just want to point out this, reflects clinical opinion and everybody using their best judgment in the absence of rigorous evidence. For the delivery room, for those of us pediatricians who've gone to deliveries and from our experience in training, PPE is standard because labor is not a clean procedure. But things that we have to do as a matter of enhanced PPE includes goggles rather than perhaps the regular face shield due to concern for contact. In this schematic, there's actually a suggestion of having the partner involved in the delivery in a virtual manner. We have not gone to that, fortunately, although we know, as Henry highlighted, controversies in New York where that was attempted. This article suggested using a mask to help contain secretions from the mother. Dr. Lyell pointed out that during the H1N1 pandemic, that was a highly unpopular ask of these moms during stage 2 labor, which is difficult in and of itself. And this is, again, one of the controversies where there's concern about infection to the baby and whether we should be permitting skin-to-skin contact and whether delayed cord clamping is a safe practice. And at the bottom, I'll highlight that, as we mentioned in prior grand rounds, there's been rapid deployment of telehealth, and we've also embraced this when we're doing prenatal consults and educating these moms about the risks they face and some of the decisions that they have to make. In the delivery room for the pediatrics team, there's just really 2 modifications that we've made. One is to use, instead of a usual open radiant warmer, we're using what's called a dual omnibed that can function both as a radiant warmer, but also as an isolette so that we can protect the infant and protect the healthcare environment when we're transporting the infant to either the NICU or the newborn nursery. And then over on the right, we've added in, this was a suggestion from our RT colleagues, a filter. The T-piece that we typically use in resuscitation is an open system. And so this filter inserted into the system helps create a closed circuit and protect our healthcare workers. And there's controversy about what to do for the triage of the newborn infant. Couplet care has become a mainstay in postpartum management. And the question is, what kind of risk does that pose to the newborn infant? Co-location is an option, and but in doing so, it is recommended that the baby be placed at least 6 feet from the mom and separated by either a curtain or an incubator or both. Parents may choose, depending on their risk tolerance, to actually separate the mom from the baby. And this allows the labor support person to stay with the infant in that regard. There might be constraints in providing a separate room. As you know, sometimes our labor and delivery and postpartum unit is impacted. And if the parents choose to separate over fear of the baby getting infected from the mother, this may require cohorting. We had briefly done that in one of the rooms of our intermediate care nursery. And so that might be necessary based on whether we have staffing or room availability to offer separation. And so it's really been a journey. In March, the CDC and the AAP issued guidance that somewhat recommended separation of the mom from the baby and to co-locate by exception, depending on institutional constraints, as I've mentioned. But it was somewhat different than the guidance from the World Health Organization, which was a bit more permissive and encouraging co-location with precautions. And as we were offering and discussing separation of baby, I think we had some pragmatic considerations, again, with bed constraints being one of them, and with a plan to primarily co-locate moms with their babies. And ultimately, I think we've really come down to a shared decision-making model where we're fairly neutral in our recommendation and we just provide education and counseling to the parents. There was some guidance issued, I think, yesterday on the CDC website that is kind of backing up to perhaps more strong language about separation of the mom from the baby. And so we will actually be having a discussion in a few hours about how we want to respond to that. Probably we won't, and I think education and shared decision making will still be our primary recommendation. Breastfeeding, as Natalie had mentioned, a very small series of 9 where the breast milk was tested and the virus was not found. And we know breast milk can actually be protective, so we certainly want to encourage that. And so we do counseling regarding whether the mom expresses breast milk or does direct breastfeeding. And if she does do breastfeeding, then we have some guidance about PPE that the mom should wear to minimize the risk to her infant. And this is just a smattering of the educational handouts that we've had to rapidly develop. We have these in English and Spanish to educate moms at the time of labor and delivery, at the time of making decisions about breastfeeding, as well as what to do when you go home. So I'm going to just transition quickly to what we know about COVID-19 in the neonate and the conventional wisdom, and I put that in quotes because I think that reflects all of maybe 3 months of knowledge, is that children were really thought to be mostly the asymptomatic carriers of the virus. And as Henry mentioned, that generally speaking, what we had known was that babies tended to be relatively asymptomatic. This is a table presented by Dr. Maldonado in an earlier grand rounds, however, that just provides a little caution in highlighting that the infants less than 1 year of age are perhaps at the highest risk for severe and critical illness if they're infected with COVID-19. So that certainly gives some pause. And then you see these news reports about babies perhaps purportedly dying of COVID-19, one in March, and then the other schematic was just yesterday on CNN. And it's still not clear whether these babies died of COVID or died with COVID. The one mentioned yesterday was a preterm infant, so there's still a little bit of a black box in our knowledge. This was a case report from New England Journal where a baby presumably got infection from a horizontal transmission after presenting at 3 weeks of life, had respiratory symptoms, did require ventilation, but recovered and was home after about a week. So it's not a truly benign disease in these infants. When it comes to testing these babies, we're currently reserving testing for infants who were born to COVID-19 positive mothers, or I should say SARS-CoV-2 mothers, not necessarily, since we're finding that some of these moms are asymptomatic. And the AAP Committee on Fetus and Newborn had issued some recommendations in April about obtaining serial swabs of the nasopharynx, throat, and if possible, ear institution rectal swabs at 24 hours of life and plus or minus 48 hours of life. It just issued new guidance yesterday, sort of giving permission not to do that second round of swabs, depending on testing availability in your institution or in the outpatient setting. I think unanswered questions, and someone asked me yesterday, is should we be checking antibodies? Should we be doing serology on these babies born to moms who are known to be positive? And I found one publication where a mom had presented at 33 weeks with respiratory symptoms, delivered at 38 weeks, and they did serology on that baby and was found to be antibody negative. And so generally speaking, when we're testing these babies, we are very much relying on our colleagues in pediatric infectious disease to guide us as these testing guidance is in evolution and constantly changing. Sorry, I'm having a lag in forwarding. There we go. So there's still some unanswered questions. What are the risks of COVID-19 to the unborn fetus? And does maternal infection confer positive immunity? We just have that N of 1. And does it depend on the time in pregnancy at which the infection occurs? There are people rapidly trying to assimilate data for newborns, including the section on neonatal and perinatal medicine from our Oxford network, registry in the UK, a registry established at UCSF, and there's a nice resource called NeoClear, which is basically a spreadsheet of all publications that people have found on this subject of COVID-19 and neonates. I can just provide some brief data about what has been published so far. This is very unscrubbed data through the section on neonatal perinatal medicine registry. They have data on a little over 300 dyads, the majority of moms who were asymptomatic. Of the babies who were tested, 12 were found to be positive. Most were put in isolation, some sort of isolation precautions, but about half were actually co-located with their mother. Of the babies who were included in the registry, most were asymptomatic, and of those who required respiratory support, I don't think we have clarity yet on whether that was because of possible COVID-19 infection or other newborn complications. And with respect to the subject of breastfeeding, we are seeing that about a little over a third of infants are doing direct nursing. Some are doing formula and others doing express breast milk or donor milk. And then just to reiterate, some of these numbers aren't quite the same as Natalie's, but the information I had as of last night was of the 18 moms that we had known, 5 who were admitted to the IC or to Stanford Hospital because of symptomatic infection, but maybe that number is 6. But of the 13 who were diagnosed at LPCH in our labor and delivery and antepartum and postpartum units, you can see that we had 6 who delivered at the time their moms were known to be positive, and so far all babies tested were found to be negative. We had just done 1 set of swabs at that point.
And thank you, Natalie and Henry, for your presentations. It's a real honor to be here and have the chance to present some of the work that we've been doing to shine a light on what's been going on in neonatology internationally with regard to COVID-19. So this was really an interesting effort that arose out of a conference that I was invited to in Jeddah in Saudi Arabia, which was organized, I'll just highlight these 2 Saudi women, Mai Saud and Nisreen Al-Kafi, who organized the 15th Hot Topics Neonatal Medicine. And during this wonderful conference, which you can see how we lose like all our credibility here, had wonderful social events. We were able to meet a lot of new friends, including Klaus Klingenberg, who's a neonatologist from Tromsø in Norway, Charles War from the UK in Oxford, and Anna Lavizari from Italy in Milan. And of course, I want to give a shout out here to my wife, Marcella, who accompanied me on this trip. I already had known John Zapanzik from Boston, Harvard, who actually previously was my mentor, and we conducted a workshop there. So throughout these couple of days, we had a lot of time, this was in February, to spend some time, talk to each other. And obviously the pandemic was already starting to take off in China and sort of slowly in other places. We had already been wearing masks on the plane to get to Jeddah. People were migrating there heavily to Mecca and Medina, which are close by. And so this was on our mind as we were leaving around February 20th. And just the day before, as Anna was returning back to Lombardy, to Milan, you can see that a 30-year-old patient there was admitted to the intensive care unit and at Codanio Hospital and tested positive. Had atypical pneumonia that was not responding to treatment. And then over the next 24 hours, this number increased to 36. And so this was a cluster of unknown magnitude that was present and likely to spread. And I think we all know kind of what happened in Italy shortly thereafter. So very quickly, they went into lockdown. And amongst us ensued really sort of an exchange on WhatsApp, mostly to figure out, what are we going to do? Because we were all pretty certain that this pandemic was going to spread to other countries. And so initially, there were, of course, a lot of controversies, and Alexis and Natalie have gone over a lot of these. And so I'll be trying to shed a little bit of sort of international light on these. So initially here back in February, early March, the epidemiological data were really limited and quite chaotic. Was there vertical transmission from mother to baby? That's still not quite known. What should we do in the delivery room? PPE was already kind of like a shortage, or talks about a shortage of PPE. What are we going to do for all these babies that are going to be delivering? Are we going to use a lot of PPE that won't be available to other providers in adult medicine? Should the mother be separated from the infant or not? Is breastfeeding going to be safe? And if we test virally, who should we test and when? So these were just some of the questions that we were trying to figure out. And then really, there was variable guidance and lack of knowledge amongst many of these, across many of these topics. And it kind of felt a little bit like this traffic light where it was just really kind of hard to figure out what to do because there was so much conflicting guidance coming down the pipes. So we conducted really sort of an ad hoc survey. It was not even like a formal SurveyMonkey survey. It's really mostly a couple of tables that we sent via a Word format to colleagues with the objective to compare national and international protocols for the management of neonates born to SARS-CoV-2, positive or suspected positive mothers, and to present the timing and process of the guideline development to the neonatology community for discussion. And so this ended up in a paper, and this was kind of an interesting experience as well. We conducted this survey between March 14 and 21st amongst 25 neonatologists from 20 countries. We had a 100% response rate. We submitted the paper by April 3rd, and we still waiting for, after approval, weeks later, we're still waiting for the actual publication. And so it's been a very gratifying collaboration with new friends and a somewhat frustrating experience in trying to provide this information to the community at large. So here are the countries that we initially reached out to. As you can see, there are mostly high-income countries as well as China. And we did want to reach out to a few like lower middle-income countries in South America and Africa, just to get a general feel of what was going on there. Even though, as you could see by these graphs, that at the time when we were conducting the survey, really there were very few cases at that point in Latin America and Africa. Europe, of course, was hardest hit at the time, and the pandemic was just sort of slowly starting to rise in North America and had already abated mostly or been kept constant in China. Here are the things that we asked our colleagues about. These included how do we organize care. This speaks to cohorting in special hospitals or in units within hospitals, delivery room and NICU management, family access, postnatal care for asymptomatic infants, testing and discharge and follow-up. And so with regard to care organization, I'm just going to provide brief highlights of all of these because of the time limitations. We essentially really found wide variation in centralization across the survey respondents. Most countries recommend cohorting of SARS-CoV-2 positive or PUI mothers and infants. And really about half the countries set up specific hospitals where these patients should be cared for. Whereas the other half tended to just isolate within hospitals. And with regard to the care of the neonates, this was kind of similar, where in some countries there was really a concerted effort to send all of these positive mothers and infants to specific hospitals where they would be cared for rather than keeping them out in the community. Now in the US, this doesn't work very well because of our healthcare system. It's just difficult to just to change LPCH into a COVID-only hospital and then send all other patients with all other illnesses maybe to UCSF, right? And so here mostly, unless it's a military hospital or something like that, patients have been kind of cohorted within hospitals. With regard to delivery room management, really all guidelines recommended caution during deliveries, including the need for personal protective equipment. And Alexis already mentioned that we, as many others, really recommended having a dedicated incubator, maybe serve as a resuscitation table as well as an isolating tool in case the baby needs to be transported afterwards to a NICU location. There really were no distinctions between vaginal and cesarean deliveries with regard to whether or not, what kind of equipments providers should be donning. There was a lot of agreement that as few providers as possible should be present so that PPE could be preserved. There were some interesting variations. So Brazil, Canada, China, and Italy really suggested no delayed cord clamping because of the concern of infection of the baby. And on the other hand, Norway and Sweden, which have handled this pandemic quite differently, as many of you may know, but with regard to neonates, they actually consider infants very unlikely to be contagious, and so they use less PPE for these likely unaffected infants. Now, if there is the need for an aerosolizing procedure, then they do also recommend isolation and PPE. With regard to NICU management, also wide variation, although the majority here suggested that infants should be isolated into single rooms or negative pressure rooms if that was available, which was only in a few countries. There was discrepancies regarding the filters, as suggested by Alexis before, and then also really where these infants should be maintained, especially in units that don't have easy isolation rooms to whether these patients could be cohorted into. Brazil took an interesting step in which they said they really did not want babies to be on CPAP because, and as you know, like many of our babies in the NICU are maintained on CPAP. More babies are on CPAP typically than are intubated. But because of the concern of aerosolizing virus particles through CPAP, they actually moved to primarily intubate these babies. With regard to family access, this is also already mentioned. This is a painful topic for many countries, NICU providers and maternity providers. Every country essentially reported a restricted regimen for family access, and in all countries, a sick parent, mother or father, was not allowed to enter the NICU. If the parents are asymptomatic, the majority of countries still limited access to one parent at the time. They would have to wear a surgical mask, and there were strict hygiene precautions. China and Poland tend to be more protective and cautious with regard to infection control, and really extended the restriction of no access or no visitation to both mothers and fathers. And Poland also limited the time of a single parent at the bedside. With regard to asymptomatic infants, the majority of countries, as you can see here, allowed infants to stay with the mother, but under strict hygiene precautions. Again, China and Poland, separation seems to be the routine practice, recognizing that the responses we got are often not really country representative, but represent the experience of a local partner in a country. In Ireland, the US and Israel, separation is suggested, and as Alexis mentioned, maybe more strongly suggested in the most recent guidelines, but mostly these countries have some form of a shared decision-making approach for rooming in if separation is not desired by the parent. With regard to breastfeeding, again, most national local guidelines support breastfeeding with hygiene precautions. Some recommend pumping breast milk, especially when the mothers are symptomatic. And Ireland suggests really pumping and bottle feeding for symptomatic and non-symptomatic patients. In China, infants are usually fed formula, and the USA, again, takes sort of an intermediate standpoint, focusing on shared decision-making, which oftentimes is a difficult thing to do because we don't have a whole lot of evidence. So it kind of it puts a lot of onus on the provider and on the parents to make this decision in the face of uncertainty. With regard to viral testing, the majority is really testing with nasopharyngeal swabs. And the issue with testing really is that when we test early after birth, we're mostly testing for vertical transmission. But as we've heard before, there's very little evidence of vertical transmission. The issue is not yet resolved, but not many babies are currently suspected in the world to have had vertical transmission. But for later testing, in many cases, you might need to wait a number of days for postnatal transmission, horizontal transmission to actually actualize so that you could test it. Most countries nevertheless recommended viral testing of all neonates born to COVID-positive mothers regardless of symptoms. And then a few countries recommended testing only if the infant was symptomatic, but there's a lot of concerns about false negatives and the lack of clarity around timing. Most countries use the nasopharyngeal swab. China also is using PCR, collecting blood and stool, in addition to respiratory tract specimens. And then again, the criteria for being declared non-infected is also not exactly clear, but often, in some countries, has included the use of 2 negative swabs 24 hours apart and clinical stability of the infant. Discharge and follow-up was maybe one of the areas least well described in many of the national guidelines. Most kind of recommended following routine procedures, but there were certainly cases of infants, and we heard this from Anna in Italy, where neonatologists actually follow infants after discharge and then see them in their practice. And she saw several patients who came kind of weeks later with an infected baby after going home with the mother breastfeeding. Only a few countries really had put into place a structured follow-up. Some countries, in order for the baby to be discharged, do require 2 negative tests 24 hours apart. And other countries recommend really early discharge, where the mother, in order to not expose the mother in the hospital, the mother would be discharged even within 24 hours, as long as she's clinically stable. So in summary, our study of this early quasi-ad hoc process of generation of national and local guidelines revealed many similarities across countries, but also many striking differences. And there were many relevant aspects for newborn care that up to this day really remain undefined and have necessitated pragmatic local recommendations. There's a lot of reasons for this variation. In part, this variation exists because the context across different and within different countries is just different. So some countries are able to exhibit a large degree of central control over the healthcare system and just order certain hospitals to do certain things. And there's also much stronger regionalization of the healthcare system in some countries than other. Background prevalence of disease is very variable, and so recommendations that may make sense in a high prevalence area may not make great sense for a low prevalence area. And also there's differences in availability of resources and supplies, where people have to make do with different guidelines because they just cannot accommodate every patient in a negative pressure room. And so in addition, when evidence is lacking of poor quality or is only indirectly applicable, then interpretation and implementation of practices may differ. Now, a slightly different reason may be that this response in neonatology has been somewhat fragmented because our field does not have really a strong international society or really a formal international society. And so there was no kind of forum to really bring together people from different countries to formulate a better, more unified response to this problem. And so I think for the future, really the lesson to be learned here is that we do need a better preparation to be able to coordinate a global disaster response, because we know the next pandemic will be coming. And the next pandemic may not be so kind to our patients. And so we need systematic efforts to create international structures for disaster preparedness, which we hope is one of the consequences out of the efforts that we're currently pursuing here. And so the key really to future responses in pandemics are really rapid mobilization of resources, rapid knowledge generation through neonatal trials networks that need lots of numbers of patients that can be studied. And so doing this internationally is almost the only way to do it. And free information sharing across countries. And so I wanted to really, before I thank everybody that's been working on this project, really wanted to highlight how proud I've been really of Stanford and CPQCC in leading these efforts. And we're really viewed internationally and nationally as really a major go-to place with regard to neonatal, perinatal care.
Thank you, Jochen. I want to thank and congratulate all of our speakers. That was really a tour de force and a really wonderful multidisciplinary team. I also want to add that something we haven't had a chance to talk about here is the impact of shelter in place and really the devastating economic impact of the crisis. And I know Susan and others are thinking about what happens with shelter in place, the safety net, housing, resources, food insecurity, and the whole impact, not just of COVID per se infection, but just everything that's happening more broadly. So I'm sure we'll get to hear about that later. It's 9:08 and all of the panelists have done a beautiful job of answering the questions. I'm just going to take the liberty of one clarifying point and then also some data about the test accuracy that we just learned this morning. Natali, the question was 5% of all pregnant women have severe disease, or 5% of pregnant women with symptoms have severe disease, or I would ask, or is it 5% of test positive women that have severe disease? So what is our denominator on that 5%? And you are muted. Make sure you unmute. You're still muted. Okay, there you go. Good, thanks.
Yeah. In that aspect, it was a combination of both asymptomatically tested and symptomatically tested patients. And of the entire cohort, approximately 85% were of milder disease, approximately 10% severe, and then 5 were the critically ill.
So then one more level to drill down, asymptomatic tested and symptomatic tested, but again, is the denominator those that were test positive?
Oh, yes, excuse
me. Yes, good, okay.
Yeah,
okay, perfect.
Pardon. They were of those that confirmed COVID positive, yes.
Perfect, yeah, that's super important. Okay, the little bit of, thank you. The one other data point that might be useful to people, there's been some really nice discussion about sensitivity and specificity, positive and negative predictive value. I think if we remember that PCR is the gold standard right now, it becomes very difficult to talk about sensitivity and specificity of a gold standard. That said, we believe the test is extremely accurate. We believe that because it is a PCR, that the false negative rate would be very low because it's such a specific PCR. But I think it's worth mentioning the rapid test because that's not PCR. And the rapid test is being used increasingly frequently in the labor and delivery setting. There's multiple assays out there, the rapid, there's Cepheid, there's Abbott, there's MENA. Our virology lab tested all of them really extensively next to the PCR before they rolled it out, and the Cepheid assay is the routine, really the only routine assay with outstanding diagnostic test characteristics, and that is the one that's being used here. The other data point I think might be helpful to people as we think about positive and negative predictive value. If your prevalence is very low, your negative predictive value is very, very high. What you really care about is if someone tests negative, is that correct, right? Are we missing disease? So one thing that we've started doing about 2 weeks ago is anybody who is coming in, an asymptomatic patient, so somebody in the community writ large who's coming in for any procedure at Packard or Stanford is being tested. As of this morning, 1,600 people have been tested and 0.4% are positive. So knowing how low the prevalence is out in the community, I think we can be becoming more and more confident that a negative test has a very high negative predictive value. So I had one follow-up question for you, Alexis. In your flow chart, you said of the positive women, 2 out of 13 retested negative. Was that like retested that day or retested in subsequent weeks or days to weeks?
Yeah, Natalie, correct me if I'm wrong. I believe that was in subsequent weeks. These were moms who were tested when they presented to the antepartum unit and convalesced and then were retested again.
Okay, so a negative test could probably means resolution of disease, not a false positive.
Correct.
Okay, perfect. Okay, 9/11. Henry, since you kicked us off, is there anything you want to add? Any closing remarks?
No, I really appreciate everyone participating, and yeah, I think we're still continuing to learn, and so appreciate everybody's input, and please reach out to us if you have further questions.
And I want to thank your service, not just to Packard, but to the entire state of California and really internationally. So this entire presentation was recorded. We'll disseminate it widely, post it on our website, make sure that other places have links to this website. We had, I think, close to 300 participants today, which is wonderful, and we'll make sure this gets out to a much broader audience. It's really invaluable. So thank you, everybody. Okay, have a nice holiday weekend.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.